Chairman, Profesor Tinica, Profesor Batrinac, mulțumesc foarte mult pentru invitația acestei simpozium foarte importante. Mă bucur mult, mă întorc la Chișinău, care aici sunt prietenii în această zi deosebită împreună cu prietenii români. Mă scuzați, merg înainte în limba engleză, e mai bine. Topic of my presentation is postoperative right ventricular dysfunction in adults, as the children is the topic of the afternoon session. So this right ventricular dysfunction, as already told by Dr. Cherin, is an important issue. And I skipped the etiology, of course, to give some message. First of all, right ventricular dysfunction in adults is a neglected and underestimated entity, is an underestimated disease, and we have proved also by the work that our group, Dr. Cherin and the group of cardiographists have done in our hospital in Novara, Italy. So, if we have a patient after operation with a good surgical correction and normal left ventricular function, or similar to preoperative left ventricular function, and you have postoperative hemodynamic instability, we should always think to be in a situation of right ventricular dysfunction, and this quite often happens. So I skipped the anatomy only to say that the right ventricle is very different from the left ventricle in terms of geometry, as shown Dr. Mureșan, geometry and function. And this is very important in assessing the dysfunction in postoperative period. And the most important thing is the flow, coronary flow. All we know that coronary flow is mainly in diastole, and this is the aortic pressure, and this left coronary blood flow, most of the flow in the left system is in diastole, while in the right system is in systole and diastole. But the component, systolic component, is much more important. And this is related to the fact that the transmural pressure is different in the right system. Of course, the coronary pressure is about 100 millimeter of mercury, and the right ventricular pressure in systole is about 20 millimeter of mercury, differently from the left system. So there's a major difference despite the geometry different from right to left ventricular cavity. And as is shown by Dr. Mureșan, right ventricle is also more resistant to ischemia, but we talk about myocardial protection because it's very important after cardiac surgery. And you know very well the law of Frank Starling that the stroke volume depends about the preload, so the distension left the ventricular and diastolic volume, and this is depending from, of course, the venous return, but the curve of Frank Starling goes up until some volume, then decrease, and this is very important in the treatment of right ventricular dysfunction. So the simple concept is that the heart can only pump out what comes in, and the main job of the right ventricle is to maintain the low outer pressure to allow a good venous return. So the main systolic filling pressure, systemic filling pressure, depends on the venous return, and as pointed out by different physiological measurement, a small increase of right atrial pressure reduces, very importantly, the venous return, and so the effectiveness of right ventricular function. And also in this diagram we see the output on here and the right atrial pressure. So we have an optimal situation of right atrial pressure that we should be maintained to have an optimal forward flow from the right ventricle. So I skipped the non-invasive study because it was presented in another presentation, but only to draw the attention that the right ventricular dysfunction starts a vicious circle in which the increased afterload, that is pulmonary hypertension, gives a prolonged isovolumetric contraction, increased myocardial stress, and induce long-term right ventricular hypertrophy. But in the immediate period, decreased right coronary perfusion, and this led to right ventricular dysfunction and also right ventricular dilatation, and so the vicious circle continued to worsen the right right ventricle cardiac output. But the main reason for postoperative right ventricular dysfunction is RV afterload. That means pulmonary hypertension. How can avoid? What should we do to avoid right ventricular dysfunction in postoperative period? First, to prevent. How we can prevent? That means operate before the onset of pulmonary hypertension. We have this very important paper. This is a multi-center long-term international study that study the prognostic and therapeutic implication of pulmonary hypertension in patients undergoing mitral valve surgery, mitral valve repair for degenerative disease. And very important results you can see here. This is mortality in patients with high pulmonary pressure. Cutoff was a systolic pressure more or equal to 50 millimeter of mercury compared to a group of patients with low or normal pulmonary arterial pressure, in which you can see that the mortality in the follow-up is almost double in patients with pulmonary hypertension. And also any cardiac events, that means atrial fibrillation or also right ventricular dysfunction or heart failure is about 2 times more important if you operate the patient late. So in this study, this longitudinal study, they found pulmonary hypertension in 23% of the group of patients. And the pulmonary hypertension doubled the risk of death and also heart failure in follow-up. And surgery is proved to be always beneficial, independently from pulmonary hypertension. The problem is that not always completely abolish the adverse effect of pulmonary hypertension. So, conclusion of this study is a very important message for cardiologists, and I think that among you there are many cardiologists. In severe mitral regurgitation, don't wait for symptoms. Don't wait for atrial fibrillation. As mitral repair is feasible in largely majority of patients, please send those patients to the surgeon quite early. Because if you send late, the surgeon can repair those valves, can operate those patients, but then the long-term results are worse related to pulmonary hypertension. Second, prepare the patients. Failing to prepare a patient with pulmonary hypertension to the operation means prepare a failure of the operation and so failure of the patient. And this was a lecture that gave us Dr. Cherin in preparing patients with pulmonary hypertension with drugs, mainly the phosphodiesterase 5 drugs like sildenafil or Revatio. And what happens in our hospital, the patient, if arrive with pulmonary hypertension and with important pulmonary hypertension, is prepared for 1 month or 2 months before the operation, of course, in case of elective operation, to reduce pulmonary hypertension and to have a better outcome postoperatively. I don't go into detail, but already sildenafil can be easily treated those patients before the operation, and adverse effects are few, and is also important for weaning adults from inhaled nitric oxide in postoperative period. What about surgery? Improve myocardial protection, and this is very important for left and right ventricle. What about cardioplegia? There are different ways of doing cardioplegia. We know from literature that retrograde cardioplegia, when it's done blindly, may induce a right ventricular malprotection. For this reason, we always, when we do antegrade and retrograde perfusion, cardioplegia, we always do selective in the right venous coronary sinus directly, so that we can protect all the right ventricle and not blindly. And of course, postoperative proper diagnosis, and this was the subject of Dr. Cherin's presentation, and treatment. Treatment means controlling the triggering factors, of course, to have a good preload. And this is very important because sometimes we try to overload those patients, but we know that the preload is extremely important to improve the output, but after a certain degree, we have worsening of, for a major distension of right ventricle, worsening of the right ventricle output. And in general, of course, generally by different papers, shows that the ideal arterial pressure is should be about 10 millimeters of mercury after the operation. So in those patients, we have frequent volume overload, in which the Frank-Starling curve decreased contractility. And of course, in this patient, we have to use carefully the filling, and diuretics will be considered, even if it fails, consider the CVV-AHF, that is filtration, cavo-caval filtration. On a hemodynamic point of view, the dilated right ventricle in the acute or also in the postoperative period affects also left ventricle geometry, as shown by Dr. Mureshan. That means that it's not only a question of pressure, but strictly the right ventricle is more compliant than left ventricle. So with excessive filling, we have a dilatation of right ventricle in a situation of right ventricle dysfunction. And this push the septum towards the left side. And so this compromise also left system, left ventricle contraction. And you know that if left ventricle contraction is reduced, also in the diastolic function reduced, we increase left atrial pressure, and so we increase also the pulmonary pressure, and this is a vicious circle that we should avoid. Oh, this dobutamine, already been told about dobutamine. The very important thing that is in experimental molded dobutamine has been proved superior to norepinephrine for not only notopic effect, but also vasodilatory effect on the pulmonary vascular resistance. I don't go into details because we are late, because dobutamine is proved to restore right ventricle pulmonary artery coupling and cardiac output better than norepinephrine. This is a very important issue. Of course, if you have a patient with low arterial pressure, we also have to use norepinephrine as well. What about pulmonary vasodilators? Levosimedan is quite a new drug that is used, and we employ levosimedan in most of our patients with important left ventricular dysfunction, and this helps also right ventricular function that, as I told you, is always, quite always, even often neglected, because the effect is also on pulmonary vascular resistance. And so we have a double effect of lowering arterial systemic resistance and pulmonary vascular resistance. Of course, levosimedan is almost always used with adrenergic drugs. What about enol nitric oxide is the only really selective drugs, gas, could be inhaled in different proportion to have a specific and selective vascular pulmonary dilatation. And when I work in San Donato, the group of San Donato was one of the pioneers of starting the use of nitric oxide in children, and after in adults, but mainly in children with pulmonary hypertension. Oh, effect, of course, but it is well known from a group that use nitric oxide that should be avoided abrupt discontinuation because we have a rebound effect, so nitric oxide should be reduced progressively. I skip the other drugs. What about effect on medical ventilation? This is very important because our patients are always ventilating in the postoperative period, at least in a few hours. So the effect of positive ventilation is negative on the right ventricular function. This is well known, but this also has been measured in this study, in which you see that positive and PEEP, increasing the PEEP, you have increasing also the pulmonary vascular resistance. This is very important because PEEP is often used in a positive patient after extracorporeal circulation, after capillary leaking in the pulmonary system. So this is very important that hand pressure of ventilation should be keep in mind to avoid, not to increase too much to avoid the right ventricular dysfunction. And you see how PEEP affect the flow, pulmonary flow. Here you have zero PEEP. You see the difference between the systemic pressure, the left ventricular pressure here, and the pulmonary right ventricular, we say right ventricular pressure, you see a big difference. So the gradient, transpulmonary gradient is very high, and the flow is optimal. And in this experimental model, if you put a PIP of 20, then you have you see a very, very reduction in the gradient, transpulmonary gradient. That means that the flow is reduced from positive pressure. And you see in those cases that also we have a bulging of the right of the septum from the right to the left system. Then I'm going to close my presentation quickly. So this is the study that has been performed in our hospital, as shown by Dr. Cherin. And you notice that 4 of those people are from Romania, and I'm very happy that they've done this study. The objective was to assess the right ventricular function in, with TAPSE and with 2D strain measurement. And I don't go into details, but it's very important that we took, of course, a patient not with previous right ventricular dysfunction. These were a group of patients, small group of patients with normal right ventricular function pre-operatively, and then they control pre-op, post-op, and also in the follow-up, the 2 measurements of right ventricular function through TAPSE and through the 2D strain as shown by Dr. Cherin, 2D strain system. And here are the results, and then I conclude. You see that those patients had a reduction from preoperative function to postoperative function, either measured by TAPSE or by 2D strain. And this was really significant reduction in right ventricular function despite a good myocardial protection. But no deaths were observed in this group of patients. And the conclusion is that open heart surgery decreased the right ventricular function, systolic function. This has been demonstrated also by other group, by 37 to 36% in this study. And the longer cross-clamping time do not affect, but these were not a very long operation. And of course, this is very important that patients who undergo open heart surgery, there is always a subclinical, not clinical evident right ventricular dysfunction. At this situation, it tends to remain stable with time. So to resolve the problem of right ventricular dysfunction, we need a team approach, and this is very important. And with that, I mulțumesc foarte mult pentru atenție.
Mulțumim și noi, doctorului Cherin. Doctorului Diena, pardon. Dacă există întrebări legate de această comunicare, domnul profesor Iliescu, vă rog.
Yeah, very good question. Thank you. Yeah, thank you for your question. I start with this study was made in a small group of patients, so the limitation is this one, and those groups do not have a very long cross-clamping time. So cross-clamping time was 70 minutes. So with the good myocardial protection, the cross-clamping time up to 70 minutes do not, if you have a good myocardial protection, do not affect adversely the right ventricular function. We don't have data above with longer cross-clamping time, but for sure, if you go 1 hour and a half or 2 hours, the right ventricle will suffer this prolonged cross-clamping time. So these were not really long, but longer, between 35 minutes and 70 minutes with a good myocardial protection. This not affect right ventricular function in our small group of patients, of course. The second question is about air embolism. It's a very important issue. And the major cause of air embolism is when we check the valve with the saline. And to avoid this, we have introduced CO2 inflation in the operative field in sternotomy and mini thoracotomy. And this system, 1 to 2 liters of CO2 in the operative field has reduced much more the problem of air embolism in the right coronary artery. Sometimes we see, but very transient. We see elevation ST in inferior leads, then disappear rapidly. So maybe this is a good suggestion to avoid air embolism during coronary artery.